I'll just say, thank you so much to our volunteer, amazing physicians, scientists, leaders, and our supporters, including California Department of Public Health, Los Angeles Department of Public Health, the Stroke Awareness Foundation, the California chapter of the American College of Cardiology, our wonderful academic partners. We are housed at UC Berkeley School of Public Health, and we have very strong and rich collaborative activities with Stanford, University of Southern California, all the UCs, and even have collaborative activities going on in other parts of the country to some extent. That is growing thanks to Zoom. And I want to say a special thank you to our scientific partners in the biopharmaceutical industry that see the value in this work to spread best practices. Next slide, please. Most of you know me. I'm the sort of connector that has brought together these amazing leaders, and I am very passionate about this work based on a lot of family history in the area of cardiovascular disease and stroke. Next slide, please. One of our co-founders came up with our slogan, which is "In the Right Care Initiative. We compete against disease and not each other." Next slide, please. Our goals are basically through controlling very important biometrics of LDL less than 100, A1C less than 8, blood pressure. We've had good success even with 140 over 90. We'd certainly like to see that better. We foster co-opetition among the competing health systems. And next slide, please. Over time, we have synthesized some of the promising best practices into this triangle of interventions that a public health officer in San Diego once said, if we were all doing all of these things, we would significantly drop events by 50%. Next slide, please. So today we are joined by an amazing group of leaders that you see with us now from across the state, including the Sansum Diabetes Institute in Santa Barbara and Kaiser in Northern California. So with that, I'm going to hand over this meeting to our fearless University of California, San Francisco cardiologist who has expertise in both endocrinology and cardiology. She originally hails from Chile and was trained in molecular cardiology at Harvard Medical School. Next slide, please. With that, I'm going to hand the facilitation off to cardiologist Evelyn Stock, and thank you so much for being with us today.
Well, thank you, Hattie. I welcome you all. Thank you all for being here. We have a very exciting program for you today. And as I think about how my career has evolved and how I encounter these patients who suffer from diabetes, if you ever want to find patients with diabetes, come to my cardiovascular clinic. I mean, cardiovascular diseases are the prime ground for finding these patients, undiagnosed, diagnosed, underserved, all kinds of, populations. And I would say right now we are very lucky to be in I would say, new wave of research and advances in treating these patients. We're lucky to have the opportunity to do this And this graph that Hattie is showing here shows you just how prevalent among different populations the diabetes diagnosis is in patients with heart attacks. And Nirali, you probably see a lot of stroke as well in your clinic, and the incidence of diabetes is probably similar, I would say. Next slide. So we have a fantastic group of researchers. We have Dr. David Kerr and Dr. Namino Glantz here from the William Sansum Institute of Diabetes. Dr. Kerr is a physician who's originally from Scotland, and he was a research fellow at Yale University, who has devoted his career to understanding how to improve health and outcomes in patients with diabetes. He founded or was involved in the founding of this Familias cohort that has been very insightful within the Sansum Diabetes Research Institute. Just a little fact is that Dr. William Sansum was the first US physician to manufacture and administer insulin to patients with diabetes. I find that fascinating, and founded this Diabetes Research Institute over 75 years ago. So Dr. Kerr has experience and is co-editor of the first book on digital health and diabetes. He has very important insights into the use of technology to treat this cardiometabolic disease called diabetes. So next slide. Dr. Namino Glantz is the Associate Director of the Familias program, and she's dedicated to managing the program and the related initiatives so that we can understand very important multicultural questions. For example, how do we address trust within these cultural families? She has expertise in social sciences research. She leverages her bilingual, bicultural experience with ease, and we can't wait to hear your presentation of how, and know more about your work with these 1000 familias, means 1,000 families, and that is a very large group to manage and to give us insights into how best to manage these patients. Please take it away, Dr. Glantz and Dr. Kerr.
Okay, so we're going to have a joint presentation today, but before I start, I'd like to extend a really warm welcome to everyone and thank the Right Care Initiative for the kind invitation today to allow us to share some of the work that we're involved in at the William Sansum Diabetes Center, or Sansum Diabetes Research Institute, as it's now known, in Santa Barbara, California. I've actually taken the liberty of changing the title because I want to discuss what I see and Namino sees as post-pandemic opportunities in underserved healthcare. And in a nutshell, the aim of our work is to address trust, access, and self-efficacy, because we believe that by delivering on those three domains, we can ensure that every person with diabetes can attain their full health potential, which is exactly the very definition of equity. Next slide, please. So I'm going to begin by setting the scene. And Namino and I published a commentary in the Lancet Diabetes and Endocrinology last year entitled "Diabetes Like COVID-19 is a Wicked Problem." And wicked problems originated in Berkeley in the 1960s. And it describes situations in society which are really impossible to solve: crime, poverty, pandemics. The aim is to resolve these wicked problems rather than trying to solve them completely. Diabetes is certainly not a tame problem. Cooking a meal, playing chess, or even neurosurgery are tame problems because you can follow structure and you can anticipate the end results. Whereas wicked problems such as diabetes are contradictory. There are changing requirements, the absence of equality, and importantly, multiple stakeholders, many of whom are rather selfish. I'll come back to that. Wicked problems have a large economic burden, and the key is that applying purely scientific solutions are completely doomed to fail. And the other feature of a wicked problem is that when one tries an intervention, it invariably has an impact or a ripple effect on other wicked problems. And a classic example during the recent COVID-19 pandemic was that at the beginning, this disease was discriminatory, and initiatives, economic in particular, aimed at trying to support people during lockdowns had a negative effect on underserved communities who were simply not able to stay at home and had to go to work, and actually were not able to access some of the financial incentives that California introduced. So wicked problems are here to stay. The background to today's presentation is what we're calling the Hispanic Latino Enigma. We know that Mexican Americans and Hispanic Latinos in general, but Mexican Americans in particular, have diabetes rates, type 2 diabetes rates that are nearly double those in the non-Hispanic whites. And they also develop it at a younger age. And sadly, we're seeing an explosion of type 2 diabetes in young people from this community, and that is a really nasty disease with early onset of cardiovascular and also microvascular complications. And it's also very difficult to treat. We also know that food insecurity is linked to type 2 diabetes, and that is a big deal in the Mexican American population. We also know that the risk of severe complications are in part due to poor glucose control, delays in the diagnosis of type 2 diabetes, and infrequent screening for complications. But beyond biology, we also are increasingly appreciating that social and environmental factors account for the majority of risk progression in this community. And also, sadly, that Hispanic Latinos are underrepresented as research participants, researchers, and providers. And with the combination of the wicked problem of the COVID-19 pandemic and the pandemic of diabetes, we are seeing that conditions are clustering within social groups according to patterns of inequality, which are deeply embedded in this society in the United States today. Next slide, please. For this group, I also want to point out that social determinants, as well as impacting the progression or risk of disease, they also have indirect effects on something as basic in medical care as pharmacoadherence. When a patient and a doctor or a person with diabetes and the clinician agree on a certain strategy to take a medicine, often the clinicians are unaware of the social factors which are impacting whether or not that person will actually take medicine. This is some data here looking at something as simple as the use of insulin in type 2 diabetes. And what we're seeing is that when a Hispanic Latino person agrees with their doctor to start an injection of insulin, the reality is that, first of all, the prescription may never be filled, the first prescription. And this also depends on factors such as health literacy, numeracy, English speaking versus predominantly Spanish speaking, where if you're a Latino and your primary language is Spanish, around 10% of those individuals who have agreed to start insulin never pick up the first prescription. And an even bigger proportion pick up the first prescription, but don't go back. They don't continue with insulin. And there are multiple reasons. We know about biological factors. We also know there's a paucity of research by race and ethnicity and the effectiveness of many therapies. But there are also behavioral and psychological and societal issues. Insulin injection has still a stigma, despite it having been around for 100 years. There is a fear of hypoglycemia. There's a fear of excess weight gain. There's also, insulin can be used to control weight. But all these factors, I think we have underestimated the impact on adherence to medication. Next slide, please. As I mentioned before, minority populations are underrepresented in clinical trials, and we have published data in both type 1 and type 2 diabetes showing this is a fact. Most of the research related to the development of the artificial pancreas for type 1 diabetes, the participants have been overwhelmingly white, female, with a college education. In type 2 diabetes, even though we know, as Dr. Stock said, that cardiovascular events are much commoner in underserved communities, they are underrepresented in cardiovascular outcome trials. They're also underrepresented as clinicians and researchers, and there's some data on this slide. In California, we're seeing 43 to 46% of the population are Hispanic Latinos, so the amount of diabetes here is enormous. Next slide. The other thing I want to emphasize today is that we do not, at Sansum Diabetes Research Institute, we do not take a traditional approach. We do not believe that a single intervention is going to satisfactorily deal with the wicked problem, and that it is necessary to integrate interventions if one wants to achieve equity in diabetes and with other chronic disease. And what do I mean by that? It's important, we'll show you our strategies, but it's important to realize that individuals cannot compensate for poor adherence to one healthy behavior with more favorable adherence to another healthy behavior. So you can have really good adherence to taking your medicine, but if your diet is terrible and your food choices consist of really bad food, then you're never going to achieve the outcomes that are desirable. Similarly, if you're inactive or don't sleep well, your food choices may become less relevant or less impactful. So we need to look towards multiple interventions beyond the traditional medical model of prescribing a single therapy. Next slide, please. So with this in mind, I want to hand on to my colleague, Dr. Namino Glantz. Namino.
So we know now a bit about what is happening and some windows into why. The question is, what are we doing about it? We see wicked problems also as opportunities, wonderful opportunities. And for over 75 years, Sansum Diabetes Research Institute, or SDRI, has looked for those opportunities to improve the lives of people impacted by diabetes through research and education and care. And at SDRI, Dr. David Kerr and I have focused on the social determinants of health, on equity, on food as medicine, digital diabetes health. And we believe that it starts with building a team that engages those who are impacted and integrates those interventions. So as in many other communities around the globe, we identified community health workers, promotores, promotoras, with trust and rapport in their circles. And we then elevated them to community scientists or specialists known as especialistas to our participants. And we did that by providing professional development in type 2 diabetes prevention and management, in the clinical aspects, including measuring height, weight, waist circumference, performing diabetic foot exams. They are trained to do point of care testing, such as how to run HbA1c tests. They're trained in the use of wearable devices, from continuous glucose monitors to Fitbits to actigraphs. And they're trained to facilitate connections and access in the local community for health and social services resources. And onto that, we layered clinical research basics such as informed consent and HIPAA and good clinical practice. We taught them how to do validated research surveys and questionnaires, inventories, and assessments. And then these community scientists or especialistas then go out and engage with our community. They create a very safe and confidential environment with mutual respect and trust. They use their bilingual and bicultural skills to create meaningful relationships with participants, entire families. They facilitate a very bi-directional pattern of learning whereby they learn from us and we learn from them. And again, they refer people to needed services beyond what they need for strictly clinical diabetes care. And these especialistas are employed and paid by Sansum Diabetes Research Institute to conduct clinical and social science research on diabetes according to strict scientific protocols. And in the process, they still draw on their community health worker peers, and they do so and are in effect able to both maintain those relationships and produce very groundbreaking, efficient, effective, and ethical research processes and findings. The especialistas have long been involved in changing lifestyle behaviors among their peer community members, and one of those behaviors is diet. And our key approach recently has been leveraging food as therapy. So we know that poor diet is linked to half of annual deaths in the United States. And with reason then, adults who are with and at risk of type 2 diabetes are encouraged to eat fresh vegetables. However, we know too that consumption of vegetables is well below recommended levels. And we also know that food insecurity is linked to poor health, including type 2 diabetes, as well as these vicious cycles whereby food insecurity provokes stress and obesity and chronic disease and poverty. You may not know that 1 in 6 people with diabetes reports food insecurity, and the more food insecure you are, the more likely you are to have diabetes and to underuse and reduce and delay and avoid medication use. We have people who are facing very hard decisions and make trade-offs between their basic needs like housing and medical bills and buying healthy foods. And this is higher in the ethnic minority populations and those with multiple chronic diseases. So for instance, 1 in 3 people with diabetes who visit food banks and soup kitchens actually pay for medication before they pay for food. But what if food, like medications, were a prescribable therapy? Well, in fact, we at Sansum Diabetes Research Institute, as well as healthcare providers, policymakers, and consumers, are starting to see the value of food as medicine, and in particular of things like vegetables and plant-based diets that improve psychological health and quality of life and A1C levels and weight for people with or at risk of diabetes. But for this underserved population with diabetes, food insecurity and their low socioeconomic status are documented barriers to nutrition-based self-management. Recently, there have been interventions tried out to treat and prevent type 2 diabetes through improved access to vegetables. They tend to be combined with diabetes education, and they've shown some success. However, no one had tested the impact of medical vegetable prescriptions alone without education, without self-management, education and support in adults with or at risk of type 2 diabetes until at SDRI, we did. We asked, can improving access to fresh vegetables lead to clinically significant improvements in cardiometabolic health in adults with or at risk of type 2 diabetes? And we sought the answer with our Farming for Life program. So following a successful pilot feasibility study and supported by a seed grant from the US Department of Agriculture, SDRI launched Farming for Life, in which 400 adults with or at risk of type 2 diabetes will receive free weekly medical prescriptions for 21 servings of vegetables a week. These vegetables, it's locally sourced and fresh, and they get the vegetables for 10 weeks. There's no additional care management or diabetes education provided. The participant health and food security are measured pre and post vegetable distribution. And then we compared baseline versus 3 months measurements of weight, waist circumference, blood pressure, A1C. We looked at food security before and after, self-reported sleep, mood, and pain, and their consumption of vegetables, tortillas, and soda. Today, I have a report on the first 235 adults with paired pre and post data in the Farming for Life program. Their mean age is 54 years, and 3/4 of them are female. 81% are Hispanic or Latino, and most of them were born in Mexico for this area. Over a third are uninsured. A third have type 2 diabetes with the average duration of around 11 years, and the remaining 2/3 have prediabetes or are at high risk of type 2 diabetes. So this is the group that received weekly produce prescriptions for 10 weeks. And what happened? Well, in just 3 months for participants with paired data, there were very significant reductions in systolic blood pressure and diastolic blood pressure. Their waist circumferences shrank, and HbA1c also decreased. And a lot of these great changes were especially significant for people who started out with higher, riskier rates. Beyond the clinical outcomes, we used visual analog scales to assess self-reported sleep, mood, and pain over the previous 7 days, both before and after the vegetable prescriptions. And we saw significant improvements in all 3 domains. People said they slept better, they felt better, that their pain had subsided. Food insecurity was cut in half from 36 to 17%. And there were also reductions in the consumption of tortillas that they ate daily, in the weekly consumption of sugary drinks, soda, and other sugar sweetened beverages, as well as the frequency of eating meals out. So yes, providing these medical prescriptions for fresh produce is associated with reductions in cardiometabolic risk factors. It's associated with improved patient-reported outcomes and greater food security. And this may be because there's less consumption of unhealthy foods. People are displacing the unhealthy foods with the vegetables they're receiving. This was, again, in predominantly Mexican American adults with or at risk of type 2 diabetes. So that's where we were starting, essentially. And what's next? We have expanded our methods to incorporate continuous glucose monitoring, and I'm going to pass it off back to David Kerr to talk a little bit about that.
Thank you, Namino. So just as background, continuous glucose monitoring, where the measurement of interstitial glucose takes place every 5 to 15 minutes over a 14-day period, has been around for a decade. But the overwhelming amount of work, research, and clinical experience has been in type 1 diabetes and insulin-treated type 2 diabetes. And it is true to say that CGM plus an insulin pump leads to the artificial pancreas in type 1 diabetes, but much less use thus far has been in the type 2 population who are not on insulin, and also people who are at risk of diabetes. And so we have been using CGM in our Latino population, applying it to people or adults who are at risk based on the American Diabetes Risk Questionnaire with prediabetes or with established non-insulin treated type 2 diabetes. In Farming for Life, these are, we already published these data, but we have more experience now. We saw, simply by improving access to better food in the form of fresh vegetables, there was an improvement in the time in range between 70 and 180 milligrams per deciliter. But we could also see in this slide here that it's possible to stratify people based on this CGM into smaller groups at risk, pre-diabetes, type 2 diabetes. And using the metrics that are applied in the type 1 population, such as average glucose, time in range between 70 and 180 milligrams per deciliter, or between 70 and 140, and also glucose variability, measured by as a coefficient of variation. Two things we saw. One, you can stratify people into subgroups, and two, there was an improvement over time in this observational cohort. We also found that, and this is a new way of looking at CGM data, if you look at the time spent between 140 and 180 milligrams per deciliter during the day, as dysglycemia proceeds, as people move from at-risk to pre to type 2 diabetes, they're spending less time between 70 and 140 milligrams per deciliter during the day. And there seems to be a relationship between that number and the measured HbA1c level. Now, why is this important? This means that, one, we can pick up abnormalities in CGM profiles at a very early stage in a person's journey towards type 2 diabetes. Two, it means this opens the potential for personalizing therapeutic interventions based on the CGM data. And those interventions, of course, could be pharmaceutical, but they could also be lifestyle. Next slide. And here's some data which is in press at the moment. But what we did here is we looked at the CGM profiles around breakfast. Now, I'm sure everyone in the audience knows or has heard from their mother that breakfast is the most important meal of the day and you should always have a breakfast. Well, she was right, because what we're seeing here is what we're calling a northeast drift as you move from at-risk to pre-diabetes to type 2 diabetes, where there's a much greater glycemic excursion, the worse the abnormal glucose profiles become in the type 2 space. Now, again, this has the potential for therapeutic interventions around breakfast time, because we also know that if you can improve glycemic control at breakfast, it is much easier to maintain control for the rest of the day and overnight. There's something about the breakfast time that seems to be metabolically very important. And we also have found that you can relate the CGM breakfast profiles to the actual HbA1c level. And these are research in collaboration with Rice University and Texas A&M. Next slide. So where do we go from here with CGM? So here's some other studies that we are planning to initiate. On the left-hand side of this slide here is my CGM profile. So I'm not overweight, I'm a wee bit old, but my HbA1c is 5.3%. So that looks really good. But I have a dawn phenomenon, which means that on waking, my glucose levels are starting to rise before I eat anything. Now, I don't know whether having a dawn phenomenon in a male of my age with my A1C, in my family history, in my blood pressure and lipids, has cardiovascular risk or not. I don't know whether it's a good thing or a bad thing. We know in diabetes that the dawn phenomenon, established diabetes, the dawn phenomenon is actually quite difficult to deal with. But in the non-diabetic individual, quite what the implications of this are, we're not sure. And we're certainly going to be taking a look at this. In the middle panel here is my CGM profile, where I had a large avocado. Now, the beauty of wearing a CGM is that you can self-experiment. And my glucose levels flatlined. There was absolutely no impact of an avocado on my glucose. But this was immediately followed by 2 very small cookies. And you can see there's a spike in my glucose. I also experimented with Coca-Cola, which is a demon drink. If you want to have a really bad metabolic profile, drink lots of Coca-Cola. The right-hand panel, as I look at it, is my CGM profile when I'm exercising. And I have significant hyperglycemia. And the reason for this is that my exercise of choice is to play squash, which is a sport where there's a massive surge in catecholamines and also heart rate. And I think that what I'm seeing here is a transient insulin resistance caused by the surge in catecholamines, because immediately after I stop playing squash, there's a fall in my glucose levels. And again, so CGM in these situations really gives you personalized insights into your metabolism. Next slide. So because of my avocado experience and also some other data, we are actually about to start a randomized controlled clinical trial of the therapeutic prescribing of avocados in Hispanic Latino adults with or at risk of type 2 diabetes. And we're going to be using CGM in this population. There's a whole host of reasons for the avocado. One, because it's popular. Two, it tastes great, but also because it's only got a small amount of carbohydrate, a lot of fiber. It's got a very favorable lipid profile. And we think that by increasing the consumption of this food, as we saw in the Farming for Life program, we're going to decrease the consumption of bad food. And that's the hypothesis we're going to test. We're also about to start a very unique pharmaceutical trial where we're doing a RCT comparing a new GLP-1 receptor agonist, oral semaglutide, with a placebo in predominantly Hispanic Latino adults with established type 2 diabetes treated with diet and exercise alone or only with metformin. So that's a traditional pharma study. The difference is that both arms are also going to be co-prescribed produce, fruits and vegetables. And again, we're going to be using continuous glucose monitoring, because we believe that if you prescribe a therapy, a medicine, it makes more sense to also prescribe better food. The end result is likely to be a more significant improvement in glucose profiles. So that's a study, the first participants coming within the next 2 weeks. Next slide. The other thing that we're exploring, as I mentioned earlier, focusing on one aspect of life is not going to cut it. So we're also looking at whether or not it's possible and beneficial to co-prescribe physical activity. And this is based on a number of studies, and one shown here, which I think is quite striking, that if you look at mortality or premature mortality in a population, these data show that compared to 4,000 steps per day, if you can encourage people to go up to 8,000, there's a 51% lower risk for all-cause premature mortality. And this goes up to 65% reduction if you can get up to 12,000 steps. In this study here, there was no association between intensity and death after accounting for the number of steps. So we've been using Fitbits and actigraphs in our Hispanic Latino population to look at their levels of daily activity. We've published some outcomes on that. And we're also looking at the time of day that people are more active, because there seems to be a relationship between this and the achieved A1C. So this is another area that we're looking at exploring in more detail. Next slide. So where is this all going? Well, at Sansum Diabetes Research Institute, we're believers in the concept of creating a digital diabetes ecosystem. And I've tried to summarize this here. And the idea is that underserved populations, we want them to have access to digital health technologies, whether it's an electronic scale, a CGM, a Fitbit, some form of device that captures food choices, home blood pressure monitoring, sleep monitoring. And you integrate these data, but importantly, we also need to integrate social determinants of health information, because that will allow us to stratify into subgroups and make personalized medicine, personalized therapeutic interventions more successful. Now, a barrier that we also need to overcome is a recognition that many participants in clinical research never get to hear about what happened to their data. There are challenges we know related to health literacy. There are also challenges related to understanding of clinical research information. And so we've tackled that head on with the program that Namino is going to tell you about now.
So we feel that to truly impact diabetes and these other wicked problems, we need to democratize both research, who participates in the research, who conducts the research, and also knowledge that comes from the research so that everyone has access to the information, and so that everyone can address what we call the infodemic of misinformation. And to that end, we created a resource. It's latinodiabetes.sansum.org to enable those who are impacted, and especially those who are most impacted by diabetes and those who are least likely to have access to the research, to access the newest, most relevant research findings. So what we do is, on a nearly daily basis, we identify the hot off the press research articles from journals and white papers. We summarize them in lay language. We add images, we attach links to more information, and we translate them. And by translate, I mean translating from very technical, clinical, scientific jargon to understandable lay language, from lots of words and numbers to images, and ultimately also from English to Spanish. And then we post them online. And this becomes a one-stop, free, mobile-friendly, bilingual resource for Latinos, Hispanics, and frankly, anyone with or at risk of diabetes and now COVID, that describes the key established and recent clinical research findings. It's information that is contemporary, it's relevant, it's understandable to professionals and lay audiences. And it showcases any new value-added strategies for improving outcomes of diabetes, COVID, and other chronic diseases for Latinos and Hispanics. It also increases interest in and engagement of Latinos in the clinical research space. So that's at Latino Diabetes, all one word, .sansum, SANSUM.org. So the type 2 diabetes epidemic is serious, it's expensive, it's disproportionately impactful. Yet what's been done to this point has not impacted minorities' risk of developing diabetes. It hasn't impacted the rising rates and the problems associated with the disease. So obviously we need to do something differently. And that's why at Sansum Diabetes Research Institute, we're challenging those usual approaches to diabetes. We aim to prevent the progression of diabetes and remove its disproportionate impact on the most vulnerable individuals and communities. And so we recognize that we can really focus on the disparities and inequities and focus on those who are disproportionately impacted. We want to engage them in research and in innovation and move upstream to focus on prevention as well as the treatment downstream. We truly take on lifestyle in integrated strategies that Dr. Kerr just described. We engage entire families, and we look at not only the biological, but also the genetic and behavioral and psychosocial and environmental determinants. We mobilize community members as scientists, and we leverage technology. We ensure that there is a two-way learning dynamic, and we enable all to access the knowledge that comes out of our work and other people's work as well. So with that, we invite your comments about what resonates with you and your work, as well as any questions you may have about all of our work. And we thank you for the invitation.
Wow, congratulations. That's really amazing, Dr. Glantz and Dr. Kerr, and thanks so much for sharing that. I think that engaging the population as scientists is so critical and especially important as we want to improve our interventions and understanding of different subgroups across America. I had a question for you guys. So I also do work with different Asian subgroups and ethnicities, and like the Latinx population, I think in Asian subgroups, they tend to get lumped together. And I sort of wonder, culturally, genetically, behaviorally, there may be differences. And so could you comment on any lessons you've learned in terms of how either study design, interventions, or outcome dissemination may vary across like Latinx subgroups, and how we can do a better job in that category as we meet with these patients and try to disseminate your best practices?
Thank you. Well, I think you've actually answered it. Do not assume that a group are all identical. For example, we asked our population, who are predominantly Mexican heritage, whether they wanted to be called Latinx. And they said, no, we don't like this. And so you need to go and ask. You need to, first of all, identify who is the target population, then say, what does success look like for that population? Not what I think it should look like. Those are two fundamental questions. And the only way to do this is, as Namino alluded to, is to identify people from the community that is of interest. So they're the people that scrutinize what you want to do, how you're going to do it, what materials you're using, this type of thing. I quickly learned that there was no point in some Scottish white guy landing in California and being able to answer the questions to why the local population have so much more diabetes. That's why the especialista, the community scientists are absolutely critical. And in the Asian population, South Asian population, so on and so forth, you need to identify people from that community and do not make any assumptions. There's a lot of data to suggest that biologically there are differences between these subgroups, but I think from a social point of view, there's more work to be done. I don't know, Nina, if you want to add any to that.
No, absolutely agree and appreciate the question. And the fact that you're asking the question means that you're probably halfway there in terms of addressing it in that population. In Santa Barbara, the predominant subpopulation is Latinos, and I said majority from Mexico. But even I lived in Chiapas, Mexico, the southernmost state of Mexico, for 10 years. I married, I had my kids there. There are so many differences among Mexican Americans from different parts of Mexico. And so not only is it key to get to know the sub-communities, but also the families within those sub-communities as a family unit and the individuals in a one-on-one relationship. And the first thing that each participant does in our programs is that they are paired with an especialista. It's a one-on-one pair. And so regardless of what they do at Sansum Diabetes Research Institute, research, education, care, or what they seek, they have that one person that they can continue to have that bi-directional relationship with and to ask questions of, and we can learn from. So it's really learning about the differences and similarities at the individual, the family or household unit level, the sort of community, subpopulation, larger population. And then there are lots of areas and challenges that are shared across all of these populations and even shared with white people among those who are underserved for any reason.
Yeah, I totally appreciate so many of the interventions that you guys talked about today are broadly applicable and need to be contextualized for the individual patient, regardless of their ethnicity or background. I see one question in the audience, and it's sort of partial because it says, can you expand on food as prescription? If Gopal Namina is here, maybe we can just promote them to ask the question verbally since it's got cut off. Jenny, maybe you could help with that. But
if they're not, I can just explain that a little bit. So participants receive a piece of paper as if it were a prescription torn off of a doctor's prescription pad. It's signed by a doctor, and it says that they are prescribed to eat 21 servings of vegetables per week, fresh vegetables, and they bring that prescription to Sansum Diabetes Research Institute and receive their prescribed vegetables. Don't know if that answers the question.
The other thing is that we don't say, what vegetables would you like? I mean, when you go to your doctor, you don't say, oh, I'd like medicine A rather than medicine B most of the time. So we provide what is available from a seasonal perspective. We can only accommodate, what's available from a farm, and that's it. We don't know what people do with the vegetables. We don't know whether they cook them, throw them away, sell them,
share them.
No idea whatsoever, share them. But when we started the program, we asked people to send images of what they did with them. And we were deluged with food, meals, which to me were beautiful and very colorful in particular. I mean, as I say, I'm Scottish, we're not used to too much color in our food, but the Latino meals were balanced, symmetrical, lots of reds and greens and matching colors. And I actually, one of my retirement dreams is to explore the use of color as a therapy for certain conditions. I'm just very interested in that.
Might have been done already. I'm not sure. I think Gopal is on. Do your question get answered?
No, I'm just following up on this. I was just trying to understand the mechanics of it. Do you give them a food voucher, or how does that work?
So the food is provided. When we set this out, we assumed, and this is where we got it wrong, that people would like or would prefer vegetables to be delivered to their home. And overwhelmingly, they said no, for political reasons, because the community we're talking about were fearful about the essentially immigration and authorities and various other things. So we asked them, well, what's your preference? And their preference was to come to a central location or locations where they could pick up the vegetables. The vegetables are provided by a farm or set of farms about 90 minutes north of Santa Barbara, and they're delivered to the central locations on the same day, and the participants pick them up or the next day. And these are fresh vegetables. We also wondered whether we should be going down the organic versus not organic route, but there's a whole literature on that. And there's an absence of good data showing the health benefits of organic versus non-organic, simply because the studies haven't been done. So we provide what is available. We have not done any work on frozen produce whatsoever, but that may be something to look at for certain parts of the country where accessing fresh vegetables all year round could be a challenge.
It is very interesting. The reason why I wanted to ask you is we are engaging in a dialogue with our 17-year-old grandson who wants to go into agricultural sciences as his major. And we asked him why. And he said, the farmers have a greater role in this area, number one, and he's all for organic farming, of course. And then he says, there is greater joy in delivering food to people. And what is called job satisfaction that a doctor or an engineer has is not anywhere comparable to a farmer, he said. And it's very interesting. This is a very interesting project because you're trying to make an impact on an underserved community, but the results come out of it also apply to the whole community.
Correct.
That's why I'm a little interested. I'm a retired cardiologist, so.
All right, well, your grandson's got it right. I mean, the future, 50% of bad outcomes in the United States are directly related to food choices. Now, it's not about, people don't wake up in the morning and say, I'm going to eat really bad food. It's about the politics of food,
True.
access, trust, and all of this. But your grandson's certainly onto something, I believe.
Yeah.
But actually, being a farmer is a really tough job. I mean, I think the nexus of food and medicine is where the future is going to be.
David,
and technology.
I think that Gopal's grandson would be interested in Veggie IQ. Do you want to say a word about that?
So we haven't mentioned it today, but I also piloted another program. I'm branding it as Veggie IQ. And it's an after-school program for predominantly Hispanic Latino, but not exclusively, where we are creating a curriculum linking food choice with physical and mental health. So we're creating youth scientists, and they're exploring ways of researching this link. They're particularly interested in mental health aspects. It's very interesting. We're giving them Fitbits, and their remit now is to create a public awareness campaign linking food choices for their communities. So this is another area which I think there's a lot more work that could be done in the preventative aspects of chronic disease by going to the young people, because they get it.
Thank you so much. I've been asked to call on Keith Emmons, who works in your area as well. Keith, did you want to come on video and comment on all this in your area?
Hi, hello. Can you hear me fine? Okay.
Yes.
I'm sorry I joined a little late, but it was wonderful to hear about this. As medical director of SenCal, right there in Santa Barbara, I really learned a lot about Sansum and the things that you do. Although I've worked with Sansum and Dr. Marjorie Newman and now her husband quite a bit with the adults in oncology. But my question for you was going to be, especially to Dr. Kerr there, a little bit more information about their after-school program, because I'm intrigued and wondering if we are doing enough at SenCal with our young population to not only educate them, but to make sure that they're starting off the road of life with the right foods through education, and to prevent and stop the development or the progression of this terrible disease. And so if there are any ways that we can work together, I want to talk with you, Dr. Kerr, and others there at Sansum about, we can talk offline about, what we can do further. I'm sure Dr. Ria Gomez, and if there's anything that we are not doing, we need to cover that base. And so my question is, what else can we do to be of service to you and your programs that you're running?
So we're actually, 2021 was the first year of Veggie IQ in the middle of a pandemic, where the young people were spending all of their hours looking at screens. So this was a huge challenge for us. So we created a hybrid model of virtual and real time. And I say we've run it, it's coming to an end in December for 2021, but we're actually, as we speak, planning to scale for 2022. We want to move into the north and also into the south, into Santa Maria, Lompoc area, and also into Ventura, Oxnard. We're also going to look at some control groups who engage with young people, where the emphasis is more on more physical therapy or on more food as medicine. So we're going to have our hybrid model compared to these other two groups. So we'd love to talk to you more about this. And we could also look at some outcomes that might be of interest to you at SenCal Health.
Thanks. Thank you very much.
This is so great to see the collaborations coming. I see a couple comments in the chat that you both can look at about interest in comparing continuous glucose monitoring and brittle versus non-brittle diabetics, as well as from Dionisio Palencia, who works on the MILPA diet in the hypertensive Mexican American population. she has some great comments there. Before we make the next transition, maybe Dr. Flynn can make one final comment, one of our sponsors.
Yeah, thanks, Marilee. And just a quick question, you know, one of our leaders early on in the Right Care Initiative was Jim Duddle, and he always came at it from a perspective of what are you going to do differently tomorrow based on the information today? Is there something you would recommend specifically for providers to do differently tomorrow than what they are doing today?
I think the community scientist and youth scientist model is worthwhile exploring for other chronic diseases. I think if you can set that up, you'll have trust, help with access, and improve self-efficacy, the three things that I said. I also, the use of wearable technologies in an underserved population. There is no barrier in terms of the concept. The barriers are about access, cost, and all those things. But the engagement by the community with digital health for prevention and reducing the burden of chronic disease is just jaw-dropping. And that's an area I think that I would do differently tomorrow. I think the CGM story is here to stay, and it's just going to get a bigger and bigger story.
Thanks so much. Well, it's 5 o'clock. It's time to transition to our next speakers. So we have Dr. Levin, one of our full professors of cardiology, and formerly has done amazing work in improving prevention in the Kaiser system as well, coming on to introduce our next speakers. I've had the pleasure of working with her, so I'm going to pass the mic, Dr. Levin.
Okay, can you hear me, Nirali?
Yeah, you're good.
Okay,
to go.
great.
You can go to the next one.
Okay, so I have the pleasure of introducing Marc Jaffe to speak today. And Marc is an internationally known expert in cardiovascular risk reduction. He first did outstanding work at Kaiser in Northern California, first to really reduce the incidence of stroke by improving blood pressure control to among the best in the country. And then he partnered with a variety of preventive cardiologists, vascular surgeons, neurologists, I'm one of them, to create the PHASE program, Prevent Heart Attacks and Stroke Every Day, to try to improve the care not only of coronary patients and stroke patients, but diabetics and CAD risk equivalent patients. From there, he took time off from Kaiser for 2 years and worked as a senior vice president for Resolve to Save Lives on a program to support hypertension control across the world in many underserved countries, and you can read about them there. He remains as a consultant to Resolve to Save Lives as he's come back to be Chief of Endocrinology in Kaiser Permanente. So I'm very proud to have been his colleague and to be his friend, and I'm excited to hear him speak today. Thank you.
Wow. Thanks, Eleanor. And I just want to start off and say it is such a pleasure to be here amongst friends, some of whom I know, Eleanor and Jerry and a few others out there, and some of whom I'm looking forward to meeting with. And I just want to start by saying that, you know, it takes a village. And when I was asked to help with population hypertension control about 25 years ago, one of the executive directors of the Permanente Medical Group said, "Hey, Marc, could you help us out? We need to work on hypertension." And I said, "I'm not really a hypertension expert." But then my boss said, "Oh, don't worry about that. You can pick really smart people to work with, and together you'll kind of figure it out." And so that's how really had the joy of meeting people such as Dr. Levin, and many others who really taught me a whole lot. And I hope to share what I've learned with you and in turn to learn a lot from you both today and in the future. So the title of my talk is The Intersection of Diabetes and Cardiovascular Diseases. And then I thought I should have a subtitle which says, Fasten Your Seatbelt, because we're going to be covering a lot of ground. Let's go to the next slide. So disclosures, just in case this was a CME meeting, but I think even if it's not, like even if we're not getting credit for this, I think it's important to know, who writes my paycheck. So that's the Permanente Medical Group, nothing to disclose. That's who I'm employed by. So let's go to the next slide. So I want to just focus on two simple questions. What should we do? And then how do we do it? And I'm using simple in quotes because it's a very simple question and it's a very complicated answer. Because in my 3-decade experience in medicine, most of the time spent at, say, scientific meetings and in the hallways and talking to colleagues, most of it's been spent about talking about what should we do. And I would argue it's probably 85 to 95% of the time we talk about what we should do. And the reality is that the small fraction of time that's devoted to how do we do it, I think that's, we may have that flipped upside down because, once we have a pretty good idea of what it is we should be doing, focusing on how to do it well is really important. And spending, agonizing over these decisions about, is drug A better than drug B? And is drug B better than drug C? And was A and B compared to C? And, should you do a meta-analysis with all those lines going everywhere? And there's even a special name for it. When you think about all the energy devoted to looking into all the nuances of the differences in interventions, I wonder if, now's the time to transition into spending, a fraction of that, maybe a large fraction of that energy into implementation energy. So today we're going to talk about what we should do because we need to know what to do, but also I don't want to lose sight of how do we do that. So let's go to the next slide, please. So I want to take a little break here and tell you about, this is my 3rd visit to the Right Care Initiative, and it's great to be back. And Hattie, it's great to work with you and the rest of the colleagues who I'm looking forward to knowing better. And I did attend UC Berkeley, so I should know better. But the first times I attended, the meetings were real, in person. And they were at the Alumni House on the UC Berkeley campus, where I went to school and quite familiar with. But I took BART there across the bay, and I got off BART and I walked up from Shattuck. And as I was walking up, I was passed by someone dressed as a knight in shining armor. I think he had a shield and an axe. He was walking down the street, and then crossing my path was a witch, with a broomstick and a hat. And then I think there were 2 Star Wars characters. Maybe Darth Vader was crossing. And, I just figured this is a regular day in Berkeley, because after all, I've spent a lot of time in Berkeley. But it wasn't till that later that day, I realized, I believe it was the Friday before Halloween. So maybe it was Berkeley in a little special time. So Hattie, I always have a special fondness for the Right Care Initiative and fond memories. Maybe not so much today on the video, but I look forward to we can get back together in person.
Well, the cool thing about doing this by video now is that we can extend our reach not only across the state to introduce people who need to know each other, but also to other states and to our federal partners. So it's really been wonderful to make this transition to virtual and to be able to see you so easily. I hope we see a lot more of you.
You got it, Hattie. And next time I'm coming in costume. So let's talk about some of the evidence. So, a lot of people will argue, what's the best evidence? which is the latest evidence. My evidence is better than your evidence. My evidence is better than your guideline. I'm sure you've all been in guideline meetings where it's a knockdown, drag out fight over one person's trial or someone's perspective. And I think that's all pretty healthy. But when I've worked for my time in the Permanente medical group and also outside viewing many different health systems, I think it's important to find a group of experts who you trust and to take a look at their guideline and maybe borrow it, use it, adopt it, modify it. You can always do things yourself like we did in the old days, but a lot of smart people have done a lot of good work, and even they have trouble agreeing. And even, you know, the kidney experts might not agree exactly with the cardiology experts, and the European group might not agree with the Texas group. But when you remove all the differences, most of what is recommended in guideline-based care is pretty standard, is pretty consistent. So I'm just putting some examples, and I had to, when I'm talking about the what, I thought, well, I'm going to look for some groups that I trust, and you may trust these, you may have a higher degree of trust in some other groups. And I think that's great, but I think you should focus on the similarities and not the differences. But here's three pretty current references that most of my talk is based on, and that's the American Diabetes Association Standards of Care from 2021, and that's updated every year. So, you know, make sure you look at it next year because it'll be a little different probably. The USPSTF, which is, it's really good, and I just want to put a plug in for the USPSTF because it is my understanding is it's generally organized from the perspective of primary care. And even though, you know, I'm an endocrinologist, I'm a specialist, there's lots of specialists on this call here. Most of the care for diabetes and for most patients for that matter is really going to be taken care in the context of a primary care setting, much like we heard today from Dr. Kerr and Dr. Glantz. So although we can argue about what might be done in the context of an endocrinology visit or a cardiology visit, it's really the minority of individuals who get their care there. So I think when they think of the USPSTF, it really does have a primary care focus. And so sometimes that's not necessarily aligned with some of the guidelines generated by experts. And I think that's a nice, healthy tension, but there are far more similarities and differences. And then the key is that there are very few differences. So let's go to the next slide. So many of you probably remember this trial. I just put this up here because I love this slide. This is the famous Hafner trial from way back in the time machine, 1998. And this is where we recognized, I don't want to say for the first time, but it did certainly make it clear that diabetes is a coronary risk equivalent. And if you look at the three graphs here, look at the purple line up at the top, that's people who did not have diabetes and who didn't have any prior heart attacks. I mean, they tend to do pretty good. The survival at 8 years is pretty reasonable. And then look at the lowest line, the red line on the bottom. You can see those are people with diabetes who had a prior MI. And if you had diabetes and a heart attack, you're at very high risk. And that's been alluded to today by some of the cardiologists who talk about the challenges they face in their practice. But look at the two lines which overlap. And statistically, that's one line, even though it's two lines, the orange line and the green line, because the confidence intervals run over each other. And so what it shows is that people who have diabetes who haven't had a heart attack are just as likely to get a heart attack as someone who has already had a heart attack who doesn't have diabetes. So from that, we came up with diabetes as a coronary risk equivalent. It's probably a little more complicated than that. But when we started thinking of diabetes as, wait a minute, they act as if they've already had a heart attack. So maybe we should be thinking about treating them in the ways that we treat patients who have had a myocardial infarction. So I think this was really started to reshape our thinking about just what sort of risk people have. Next slide, please. So then here's another famous trial. And for those of you that that into numbers, I'll just say 0.052, that was the p-value. And there's been a lot of discussion about the UKPDS trial, but you know, depending on how you want to spin it, some people say this is almost significant, or you know, should have been significant or was not significant. But the reality is that the UKPDS, the big English trial, really pointed out that treating that if you're going to treat people with diabetes and focus on their blood sugar, depending on how you want to look at this, complications can be prevented by controlling blood sugar, but it's not a slam dunk. Wasn't entirely clear that treating blood sugar could reduce the risk of heart attacks and strokes, macrovascular disease. It's definitely good for, you know, eyes, kidneys, and nerves, but I think it was, you know, close, and you can spin it either it was helpful or not helpful, or almost helpful or barely helpful for macrovascular disease. So let's go to the next slide. So what do we learn from that? Well, what we learned is that improving blood glucose control is definitely good for small vessel disease and might be good for big vessel disease. And in a way that, in my mind, that was really important, because it made us think, well, maybe we ought to double our efforts to focus on the other things which we know really make a difference. And that would be the additional cardiovascular risk reduction strategies to prevent heart attack and strokes, blood pressure, statins, antiplatelet agent for secondary prevention, these sorts of things. So I think that was a good thing that it was controversial. The P of 0.052, you know, not less than 0.05. Let's go to the next slide. So let's talk about blood pressure for a second. Next slide. So this is a source of considerable controversy. And you know, it's really hard to go to it's really hard to pick up a journal article or read a guideline or go to a conference where there's not like a counterpoint about, you know, what should the blood pressure target be. And I would point out that amongst multiple guidelines, whether it's the American College of Cardiology, the European College of Cardiology, the American Diabetes Association, the USPSTF, the American Academy of Family Practice, you can find some subtleties about what the blood pressure target should be. And if we just pick the American Diabetes Association 2021 guidelines, which is one I've referenced, what they say, and I think it's a pretty reasonable recommendation, which is, look, everyone should have a blood pressure less than 140/90, and that's level A. And they define level A as their best level of evidence. And it's something like one or more than one randomized control trials, which are done really well. And so they say, well, we're pretty confident that's a good thing to do. And they say, yeah, and then, you know, if you're high risk, you should have an even lower blood pressure if you have diabetes. And they define high risk a number of ways, either established cardiovascular disease, other atherosclerotic disease, or high tenure risk. And, you know, the level of evidence isn't quite as great. It's a level C. So, and I think, you know, what does that mean? Does that mean that, you know, what does that mean for an individual? What does it mean for a population? Well, I think when I take a look at this, when we were thinking about the large population in front of us, a risk of problems, let's put most of our focus on getting everyone under 140/90, because I know some of you are from very high performing healthcare systems where you've got lots of people at that goal. And I know in other systems, not necessarily throughout the world, in our own state, in our own backyard, there may be a lot of people who aren't even at the 140/90 goal. And for an individual, yes, you know, first order of business is to get that person down under 140/90. And then I think the second order of business, if the person's high risk, is to try to go a little lower, knowing that the energy and effort required to do that is higher, and that the evidence that that's beneficial is, I would say, not as certain, at least when you look at the level and the strength of the evidence by the American Diabetes Association and others as well. So I think that's something to think about. And my tip would be, well, let's, as opposed to arguing about which is more important, let's get everyone to the first goal and then as many as we can to the second goal. Let's go to the next slide. So what drug? So we know what the goal should be, but what's the best drug? And it's really interesting when we talk about diabetes and what drug we would do if we want to prevent cardiovascular disease. Because if you read the literature carefully, and if you look at most guidelines, what most guidelines say is that, well, if you have diabetes and you want to get the blood pressure in control, you can really use any of the 4 classes of drugs which have been demonstrated to improve cardiovascular outcomes in large prospective trials. And those would be ACEs, ARBs, calcium channel blockers, or thiazide diuretics. And yes, for the 15% of people that have established ASCVD or microalbuminuria or macroalbuminuria, it's a little different, probably should be ACE ARB. But if we focus on the vast majority, the 85% of individuals who do not meet these criteria, then any of the 4 drugs would be okay. So I think the tip here is that although we spend a lot of time arguing about which people might benefit from being in a certain high-risk subset, that for most people, any of those 4 drugs is probably okay, at least if you read most of the guidelines I've mentioned. So let's go to the next slide. So how many drugs? And I think this is new. And I think when we start to talk for the second half about implementation, I think this is an important point, that if you read the American Diabetes Association, if you read the details, beyond their recommendation, and frankly, it takes a lot of energy and effort to sort of read the text and the rationale behind their graded recommendations. But they say you may use 1 drug if the blood pressure's less than 160 over 100, and that's not a graded recommendation, that's a comment. And they say, but 2 drugs are recommended if the blood pressure is over 160 over 100, and that's not graded either. So how to interpret that? Well, I'm a lumper, not a splitter. And so I figure what that means is that, well, it's probably a good idea to use 2 drugs for most people, but there might be some who you can get away with just 1 drug. And I remember we would have this trick question when I was attending on the and I still do this sometimes, and it's a trick question if you ask somebody what the best drug is, and someone with hypertension, especially someone with diabetes who has hypertension. Really, it's a trick question because it's very unusual for people with diabetes to have their blood pressure controlled only 1 drug. So really, maybe a better question is what combination of drugs, or what's the best second drug, or what's the best 3rd drug. So I think the takeaway here is, although 2 drugs are, 1 drug might be used, 2 drugs are recommended if you read the fine print. So for most people, it probably would be reasonable to start with 2 drugs. Next slide, please. Let's talk about lipids for a sec. We're halfway through this. If you read the lipid section, it's hard, it makes me dizzy, right? And just reading this, and I don't know how on earth we made lipid care for people at high risk of cardiovascular disease so gosh darn complicated. But if we just look at the level A recommendations, really, if you have diabetes age 40 to 75 without known heart disease or other atherosclerotic cardiovascular disease, you should use a moderate intensity statin. And I won't go over what drugs qualify for that. I'm sure you all know that. And that's level A though. So that's the greatest degree of evidence. And then when you look at the secondary recommendations, which are graded strength B's and C's, yes, people who are younger might be reasonable to start a statin. Yes, people at high risk, especially if you've got other risk factors, it's reasonable to use a high intensity statin, right? And for people with a 10-year risk that's very high, might be reasonable to add something in addition to a statin, such as ezetimibe, to get that LDL very low. Again, even lower quality of, lower graded recommendation based on evidence strengths. So when I look at all this, and I'm thinking about, the second part of our challenge, like how on earth are we going to implement all this? I look at all this, I say, well, if we just do the boxed recommendation, if we use moderate intensity statin on people with diabetes who haven't yet developed heart disease, that we're getting a lot of mileage out of that because we can be the most confident that that's the most likely to be effective. It's the least risky, right? Least risk that we're doing something which isn't helpful because it's the highest grade, at least based on American Diabetes Association recommendations. And other things are bonus, right? And if we can get around to doing the rest of things, that's great. But maybe we should focus on getting as many people as possible on moderate intensity statin. And yes, a secondary goal would be the recommendations for individuals at higher risk for whom we might use a higher intensity or more agents. So let's go to the next slide. What about aspirin? And Hattie, I wish I gave this talk a month ago. I would have been able to skip this slide, but timing is everything, right? So for those of you that are reading, any social media or the news, because you don't really need to read any journals to have this dropped in your lap, you probably heard a lot of activity about aspirin. And, aspirin's a funny drug, right? Let's just take a step back. When you think about, safety and risk profiles, and if I took anyone on this call who obviously you have an interest in cardiovascular health, and if I said, oh, all the records of what drugs are available by prescription, the book which says what needs to be prescribed, we lost that book. We lost it in the flood. It was in the basement of my house during this last storm. It got flooded. So we get to make up what drugs are available over the counter, which is what's by prescription. I wonder if you would really make aspirin a drug that would be over the counter. When you think about its risk profile, and if its benefits profile. And it's over the counter because it's been over the counter forever. But I kind of wonder, like, if you would make aspirin available by prescription and statins over the counter. I kind of wonder about that because gastroenterologists aren't calling you up in the middle of the night, complaining about the GI bleed of this patient that you put on aspirin. Maybe occasionally you get a call from someone that's achy on a statin, or there's rapids on a statin. So I just think that, but we are where we are. We got to think about aspirin. So I think aspirin was sort of probably, I think the toxicities of aspirin weren't necessarily appreciated, back in the day. But we're in this day now, and if you look at the 2021 guidelines from the American Diabetes Association, they say, well, maybe aspirin might be considered if you're increased cardiovascular risk after a comprehensive discussion of their benefits and risks. Okay, that's a little hard to digest. And what do they mean in the fine print? Well, if you're sort of middle-aged or 50 to 70, maybe that's not middle-aged, and you have one or more risk factors, such as high blood pressure, diabetes, or smoking, which is basically everyone with diabetes, right? Because how many people with diabetes don't have any of those listed risk factors? Then you're not at increased risk of bleeding. So if you're not over 70, you're not anemic, don't have chronic kidney disease, then you may be considered. Okay, so it doesn't mean need to be on it, might be considered. And so what did the USPSTF say recently, a few weeks ago? Well, they said, well, looks like there's a lot of bleeding, right? And the amount of bleeding that you get, GI bleeding and hemorrhagic stroke, may actually exceed the number of fatal and non-fatal cardiovascular events that you tend to get. And clearly, I think that the problem here is that as you get older, your risk of heart disease goes up, but your risk of a serious bleeding episode goes up even more. So unfortunately, the people at greatest risk of coronary disease, right, just based on age, are probably at even greater risk of an adverse event from aspirin. So this is it's a proposal. If you don't like this, go ahead and send your comments to the USPSTF. But I kind of like this, and what this really kind of emphasizes that aspirin's a special drug. It's a dangerous drug. It's a great drug if you've already had a heart attack or stroke, right? Great drug, right? But if you're trying to prevent a heart attack or stroke, maybe this isn't the first drug you reach for. Maybe there's other better drugs to think about. And there's so many caveats on it that I really wonder whether or not it should be over the counter or not. But we do recommend And it's another opportunity for us to counsel people who are or aren't taking aspirin. And so when people ask about aspirin, think, well, maybe there's other drugs you could take. Yeah, Hattie.
Before you leave the aspirin topic, Kaiser has a very long history of using the all protocol, the aspirin, lisinopril, Lipitor, or lipid-lowering agent. Can you just talk about what you see in your data? Because you've had phenomenal success in dropping heart attacks, and aspirin was part of the formula.
Yes, that was part of a mantra from Southern California, and in Northern California, it's called PHASE, preventing heart attacks and strokes every day. So when, I think, and then by the way, the L in ALL, one of the L's was lisinopril, but as we know, there are many ACE inhibitors. So it was a catchy name, but you're kind of stuck with that name for a while. I think that I don't have any data, but I do know that, aspirin has always been hard to quantitate and measure because it's available over the counter. And it's, you could easily keep track of how many people are getting a prescription for a statin, and we have excellent internal data on that and shared with NCQA HEDIS, but it's much harder to get data on who is and who isn't taking aspirin. So, I think that for similar to, and we do our best to, do medicine reconciliation, but I'm just not as confident that our confidence in knowing who's on that is as great as something available by prescription. So, I don't know, but I suspect that, I would hope that the numbers are likely to be, less and less moving forward. But, it's not, maybe it's good that maybe it's good that it's not by prescription because maybe people weren't taking it because we tell them to take it and they wouldn't because there's no prescription, or maybe it's bad because people would take it and not tell you. I don't really know. But it is sort of funny that one of the cornerstones of treatment is not available by prescription. And so it's up to us to document it, but it's tough.
So just for clarification, was aspirin part of the PHASE program in Northern California also? And I know that Eleanor 11 helped you in leading or developing that. I'm not sure which.
Yeah. So again, with the Preventing Heart Attack and Strokes Every Day really was a program which was really more of a movement. And I can show you an example of later I'll show you an example of a protocol, which was an algorithm. But if you look carefully at it, you'll see that it's like version 19. So it's a living, breathing document. As guidelines change, we change our intervention and execution. So, aspirin's always been a funny drug, and it was definitely recommended for most individuals as secondary prevention, as most guidelines say. But for primary prevention, I think we've seen a decreased emphasis on promoting aspirin for primary prevention. As y'all have seen over the years, there's been a greater and greater reluctance to recommend aspirin in people with diabetes and other people at risk.
This is Eleanor, Hattie. I definitely think we're up to like version 35 of PHASE on a Page, which is accessible on the internet to see what the latest recommendations are. And so as Mark said, it changes every year, every 6 months, adding new drugs, taking others off. It's a very sophisticated protocol for Northern California. It was never simple. So part of that was that Jim Duddle really wanted to make it super simple for Southern California. But in Northern California, we had a group that each had very strong ideas and had, the cardiologist guideline, the internist guideline. So since it was a very sophisticated group, all with competing guidelines, we had to agree, and it's actually a very complex algorithm. Now it can all fit on now 2 pages, but it's never was simple. I guess that's what I wanted to say.
I'll just add one more point to underscore that these are all packages, and nobody knows, well, we have some research on what the individual benefit of each component of the package is, but some of the great benefits we've seen in these interventions are from the whole package. Maybe it was driven more by the statin, et cetera. So Hattie, it's okay that they were positive effects from those phase interventions, even if we're taking out the aspirin now as we've evolved.
Yeah, that I just want to add one thing to this recommendation, and that worries me, is the subpopulation of people with elevated lipoprotein A. Those people, as you know, are at increased risk due to the prothrombotic and pro-atherosclerotic effects of lipoprotein A, and we have good evidence that lipoprotein A, people with elevated lipoprotein A, benefit from aspirin. So I would like to see this recommendation have that caveat if possible, because I think it might be a disservice to this subpopulation. Any thoughts on that?
Yes, thank you, Eveline. So I'm here. Okay, okay. And I'm going to say absolutely in your clinic, in your specialty preventive cardiology clinic, absolutely, that's different patients. But again, USPSTF is really geared more towards primary care, and the number of patients with isolated elevated issues that you describe is probably low. And I believe that they may need special attention. But this is really a blanket, this is a blanket recommendation, I think, for execution in the primary care setting. And so I always think there will be exceptions and always be rules for specialists. But I think Eleanor pointed out that, the more complicated things is, the harder it is to execute. And, I think I just wonder about the number of people who are harmed by taking aspirin. And so I think that's probably the stance of USPSTF is. But this is just my take on it, and y'all can, they're taking comments. So you should, provide your comments and see what they have to say. Let me move along here and going to the next slide. So in the diabetes medications, so this is also quite tricky. And so, they're pretty smart over there in Boston, at least they think they are. So, we might have people from Boston on the call, right? Because it's international now. So if you're from Boston, then we think we're smart out. We think we're pretty smart out here too. This is from actually from, I believe, Johns Hopkins, but it was published in the New England Journal of Medicine. So maybe it's really from Baltimore, not Boston. But it's a really great update on the cardiovascular drugs for people with diabetes. And it came out just earlier this year in 2021. And, they point out the same thing, that glycemic targets are important for micro and macrovascular complications, that for most people should shoot for an A1C of under 6.5 or 7, but they need to be individualized, because some people can get lower than that much easier. And unfortunately, some people have great difficulty getting there, and it may just be unsafe. So you have to think about how risky it is for the patient and how hard you have to push to get them there. And then what's also interesting is that you can use cardiovascular disease and cardiovascular risk status to help think about what diabetes drugs might be appropriate. And that's sort of new in the past several years. And what they focus on, we'll talk a little bit about, is that people with diabetes and known cardiovascular disease, and in certain people at high risk, but the studies in the high risk patients, much fewer studies in the people with established cardiovascular disease. Well, then you should think about two specific diabetes drugs, which happen to be, which are pretty new, and like most drugs, they may not be as affordable for patients, but they may have great benefit. And those would be the GLP-1 receptor agonists or the SGLT2 inhibitors. And then for people with heart failure, same is true, except that's probably just the SGLT2 inhibitors that can be beneficial. So let's go to the next slide. And so I think this is a nice, really great slide about how to conceptualize this. So what it says that, listen, most people get metformin and lifestyle changes, because metformin, when used as monotherapy, doesn't really cause a lot of hypoglycemia. And if you don't have any cardiovascular risks, then you're at your target, that's great. But even if you're at your target, you should consider adding some medications for diabetes. And what's really interesting is that it's really not about getting the A1C lower. It's like, hey, if you're doing well and you have diabetes and you have heart disease, then maybe you should add a GLP-1 receptor agonist or a SGLT2 inhibitor, right? Because you can get some improved cardiovascular benefit, kind of regardless of your A1C. And for heart failure, yeah, maybe add a SGLT2 inhibitor. So I think that's kind of it used to be, well, the A1C was good enough, so we're going to move on. But now it's like, hey, if you can, you should consider adding these drugs. Let's go to the next slide. I think before I get to that, I'd say there's some, say, how do I do all that? Well, I'd point out that the drugs which everyone's excited about are for many patients quite unaffordable. And so that is a major barrier. But if we think about all those things I mentioned, that's nice, but how do we do all of that? Or how do we do any of that? And go to the next slide, please. I think what I can say is that it can be done. And so this was something we published about 2 years ago about reducing risk factors in the American Journal of Medicine. And we looked at risk factors in patients in whom we had after the implementation of our PHASE program, Preventing Heart Attack and Stroke program in Northern California. Let's go to the next slide. And here's another little funny story, is that when we sent this paper in, one of the criticisms we got from one of the journals was, wait a minute, you can't submit that diabetes paper with all the interventions that you did, because that's a ripoff. That's almost exactly what you did for hypertension. It's almost verbatim what you did for hypertension, but you just crossed out the word hypertension, you entered the word diabetes. And the reality is that, yeah, that's what we did. Basically, we addressed hypertension in Kaiser Permanente, and then we moved on to diabetes. But I guess for some people that was a criticism, but I view it as actually being quite similar, the systems and concepts. So if we move to the next slide, what were the key components? Of all those things that we needed to do, or the new things we'll need to do, what were the key components? Well, we developed a registry, which is like a list of everyone who needs something, clinic level performance feedback, so that we could see how well we're doing. A treatment algorithm, as has been mentioned here, that you have to know what it is we're going to do if we're going to implement something. And then we had team-based care. We involved nurses and pharmacists and others. So let's go to the next slide, and we'll talk about some of the details of these. So what's a registry? Well, a registry is a system that collects data, and they're valuable to complement or randomized controlled trials and determine real-world outcomes when you want to transition that into the real practice of medicine. They don't really have inclusion or exclusion criteria because it's not really a trial, but it's just a master list. And it's really helpful to get your arms around the universe of patients that you're trying to treat. So maybe one could start with a diabetes registry if we wanted to execute on all of these good interventions we talked about. Go to the next slide. So what should it look like? Well, it should identify most people, maybe not everybody, because you have to balance sensitivity and specificity, but most people, or almost everybody, should also validate this against expected disease prevalence. If you know the prevalence of diabetes in your community is 5 to 11%, and you look at your registry and you only have 4% of your population with diabetes, then maybe you need to work on your registry. And you should review it periodically to confirm accuracy. It needs to be regularly updated because people move in and out of the registry. And then you have to balance how many things you want to add to it, because as these registries get complicated, they're hard to maintain. We talked about how hard it was to maintain websites earlier today, but I think it's important to make sure a registry has to be manageable. So let's go to the next slide. And then the good thing about a registry is once you have a registry, once you have your list, you can do a lot of stuff with it. Like if you say how many people have diabetes, and the answer is I don't really know. I don't know who's in my catchment area this month. It makes things difficult. But if you have a registry, you could say, wait a minute, maybe we could look for people who could benefit from one of the newer cardiovascular agents and reach out to them. Or maybe you could see who's overdue for a visit or a test, or people who are in a high-risk subset, as we mentioned before. So, just having a registry, even if it's not a perfect registry, is really helpful to get started and to help prioritize your interventions and to look for people who might need a little extra help. Let's go to the next slide. So once you have a registry, once you have a list of everyone, then you can start developing performance feedback. The performance feedback, we did initially quarterly and then moved to monthly, but you can identify those clinics that are doing really well, and you can go to that clinic and find out what they're doing well, and then maybe export that to other clinics. And what we've done in Permanente Medicine is we focused on intervention at the clinic level for performance feedback more so than the individual level. Because if you focus on the clinic is in a position to reorganize itself to execute on those deliverables. Whereas it's a little more complicated for an individual provider to be told how he or she is doing it, from him to be able to, he or she to act on that information. So let's go to the next slide here. This is from a presentation way back in 2001, believe it or not. But again, I've blinded the medical centers here, but this was a hypertension control report, and you can imagine something for a diabetes report or a statin report or a who's on aspirin, who might need to be on aspirin or who shouldn't be on aspirin. But you can rank your medical centers and share this, and then medical centers 1 through 15 can learn from medical centers 16 and 17. And this is a really effective way of promoting operational change. Let's go to the next slide. And the drug treatment algorithm, I won't go over this very much, but Eleanor had already mentioned that, you know, every 2 years or more frequently, it's updated because things change. Like things might change in a month or two when the USPSTF or aspirin recommendation comes out. And we involve a multi-specialty group with a lot of people, and we try to keep the algorithm simple. And Eleanor, it is complicated, but it's complicated and simple at the same time, because it's a lot, in my opinion, when you see some algorithms out there, it can be quite head spinning. And I think ours, like many, really tried to make it as simple as possible. Let's go to the next slide. So this is, and I can't read the fine print, but I think this is, I can't read, it's too fuzzy, but I think this is version 19 or 19.2. So maybe there were 30 or 40 revisions.
It's actually version 34, because I know.
Oh, up there. Yes, I see it. Upper right. Yes, I could see it.
I recognize it. Yeah, but we've gone on since this, but,
yes.
But I recognize 34 because it's got liraglutide and pioglitazone. Yeah, and that was on the ones before.
So this is just an example, but again, if you can come up with an evidence-based treatment protocol, which is going to work for most patients, then you can see that you can kind of move stepwise through this. And once you've decided what it is you want to execute on, you can kind of move forward and try to deliver on these, these care options. Let's go to the next slide. And then last, I want to mention team-based care. And I think the key is that the more simplified the treatment algorithm is, the easier it is to do task sharing. Because if there was no protocol or algorithm at all, it'd be really hard for everyone to practice on the same page. But if in your clinic or if you're in your group and your care system, based on your formulary, based on the unique perspectives of your specialists and the needs of your patients, you can come up with something like this, and it can work for you in your domain. And this is a lot of what I did externally for 2 years in different parts of the world, trying to have them come up with what package would work with the resources they had, with the drugs they were comfortable with and that were affordable for their patients. And once you have a treatment algorithm like that, you can imagine it's much easier to start to think about task sharing, having nurses, pharmacists, and others operate to the top of their scope to be able to deliver the care and to support the doctors and the rest of the care team. And these are adopted from guidelines. And remember that it's not going to work for everybody. So it will probably work for 80% if you do it right, and 20% will need something different. And there's always be room for specialists to help for those tough cases. So let's go to the next slide. So does it work? So here's just a publication from a couple of years ago. And yeah, it does work. In other words, A1C under 9 was, using this program was better in this when we use this program compared to external comparators. LDL control under 100 was improved. We go to the next slide. hypertension control, which this is a slide for people who have diabetes and who don't have, but also other people in Kaiser Permanente. But hypertension control, again, using a similar system, is the blue line on top, was improved using this sort of care model. And as we go to the next slide, you say, well, that's nice, you've improved the surrogate markers, but does it improve the outcomes? And this is from a combination of 2 trials published up till about 2014, where we saw the rates of STEMIs and MIs dropping. It's hard to get an external comparator, but at least within our own organization, we saw these numbers drop. So next slide. So I think, when we think about, at least when I think about this, what do we do about diabetes? We have to understand the evidence, and I wouldn't get too hung up over what, on the nuances, because I think most, you can probably pick a guideline which aligns with your belief. But we maybe spent a little less time focusing on the differences in the actual differences between the guidelines and focus that on interventions. And the more you can standardize it and scale, because that would lead to more simplification, then I think the better off you'd be. Because it'd be, the more complicated you make something, the harder it is to pull off. So next slide, please. That was the end of my diabetes and cardiovascular disease update, the intersection. And so hopefully I've shared a little bit about what you should be doing, but also how you might go about doing it. So I'm happy to respond to any questions or comments. I know I've taken a few at the midpoint, but I'm happy to see what you guys have to say.
Could I just start with one? I know the wonderful work that you did for 2 years all across the world with reducing hypertension. Did you address diabetes in those populations, and could you see a formula that would be affordable to reduce diabetes in Vietnam or Asia, where they're having this explosion of diabetes?
So Eleanor, you remind me of, so almost everywhere we went, they said, and you'll get a kick out of this, they say, oh, you're doing this hypertension program, can we just do diabetes too? And I'm like, oh my goodness gracious, we're gonna just do diabetes too? And the challenge is that, imagine, in these places in developing nations, that, so the thing is, it's tough, Eleanor, because the risk associated with diabetes care and the amount of monitoring and just the technology in terms of blood sugars, it triples or quadruples the complexity. So what we usually said was, hey, listen, most of the patients with diabetes their urgent need is to address a lot of these other risks. And you can maybe start with hypertension, learn how to do that, get that system done, and then you can sort of roll in diabetes care. Because you can imagine going from 0 to 100 all at once is quite challenging. So we encourage them to do usual care for diabetes and to learn how to do system care with hypertension and to fold in diabetes, because we want them to be successful. And if you do everything all at once, it's hard to be successful. I think the concepts are the same, though, to be honest with you. It's get an evidence-based protocol, figure out who you're treating, use a metric. It's those 3 things. You do those. I mean, I said this in country after country after country. You did those 3 things. You could do anything: diabetes, hypertension, asthma, anything.
Dr. Jaffe, thanks so much. And I appreciate what you're just saying, and sort of thinking about the previous speaker and how, you were sharing the debate on the interpretation of some of the studies. How does Kaiser do sort of community-based participatory research or engage the community in giving back that research in a digestible way, sort of what we were hearing about from the first speaker?
So one, we're committed to partnering the community. I think I'm in the community right now, right, with all of you. But also we had a lot of grants through the CCI. I don't even remember what it stands for, but it's something initiative. But we actually helped implement phase in, I think, 30 or 40 programs in Northern California and Southern California using the safety net, where we helped them with the general principles of cardiovascular care. And I think part of what we want to do is just let people know what our model is. And you might hate it. If you hate it, use your own model. If you like it, take the parts you like. But it's really about simplifying it and standardizing it and not worrying about what the details are. So that's what you want to say. It's only hard because we make it hard.
I totally agree. And as someone who does global health work as well, I see that, we have all the information. It's really how do you translate it to those individual groups. I'm going to call on Dr. Kerr, our prior speaker, who had a question about continuous blood pressure monitoring.
Oh, it was just really your comment on the value or otherwise of 24-hour ambulatory blood pressure monitoring in the diabetes population, nighttime dippers versus non-dippers versus reverse dipping in this. Is there anything special in the diabetes population or not?
I don't really, that's not my area of expertise, so I wouldn't feel comfortable saying it. But, whether you dip or whether you don't dip, we have an epidemic of uncontrolled hypertension. And I think checking at home is better than checking in the office. And that's for sure. So whether it's a monitor, 24-hour, I think we need to do better than just coming in and being scared of the doctor office and having your blood pressure go up.
Awesome. There's a question in the chat box. Sorry, the name is getting cut off on mine, but and it's a topic we've talked about in this forum before about collaborative practice agreements between pharmacists and physicians. And maybe you could share your experience on how you do that and how you eventually maybe transition more responsibility to the pharmacist or other providers to practice at the top of their scope.
Yeah, well, there's lots of literature showing that pharmacists and also other healthcare providers, pharmacists and nurses, for example, are really for hypertension. And I don't know about diabetes, but there's lots of literature that pharmacists are as effective, if not more effective, under protocol than usual care. And I think that it is definitely it may be in some places more about, I'm not saying in Kaiser it's this way because it's one big happy family under one roof, but I think in other places there may be some competition, and whether it's healthy competition or unhealthy, I won't comment. But I do believe there's roles for everybody, and physicians can't do it alone. We can't say you need to do all this stuff and we're the only ones that can do it. It just doesn't work that way.
And I think the specific comment is, how did you graduate responsibility? Did you start with lower scope, teach, expand, and iterate, and then get to more responsibility to the pharmacist? Or was there sort of a set protocol, maybe practical implementations, if that's the theme of a pharmacy agreement?
I don't know if there's a standard in Kaiser transitional protocol on how we got from here to there, because we're pretty big. I do know that so I don't actually know all the details about how we got from where we were to where we are now, but we do use a lot of pharmacists now.
I could just make one comment because I was directly involved with the heart failure program when we set up the heart failure protocols, and we particularly partnered when we started, and this was 25 years ago, with an RN and a PharmD. And the PharmD, by their state license, can furnish the medications, and the RN can titrate medications based on nursing protocols that are filed with the director of nursing at your hospital or facility. And so it's a wonderful partnership because the RN has more experience in assessment of neck veins, chest, physical exam, and the pharmacist has more expertise in medications and furnishing. So that was the partnership we used, and we did not use advanced care providers in terms of NPs or PAs. We just used PharmD and RN together with physicians for questions that came up off protocol. So that's one way to create a program with this wonderful partnership of each person working to the top of their license. And in the phase program, which Marc directed, by the way, for many years until he went to Resolve to Save Lives, we had that with the medical assistant. We had the medical assistant working to the top of their license, which I just was speaking to a medical assistant at Kaiser today. It produces such pride and satisfaction in their job that they're not just putting people into rooms, but they could do the checklists and could, you know, put the medications in that the patient was taking or not taking, make the callbacks. You know, it's great to have the whole team work together.
Yeah, thanks, Eleanor. I would say that we did 100%. We involved nurses and pharmacists a little more heavily in diabetes care and medical assistants a little more in standard hypertension titration. Now, the prevalence of hypertension, right, it's 20 to 30% depending on age and demographic. Diabetes, 5 to 11%. So just on the volumes and the numbers and complexity and staff, you can see how that's a nice fit. But absolutely right, and we do try to use as many people as we can to the full scope.
Okay, I promoted Gopal Nemana is back with a question, if you want to verbalize it.
Yes, actually, Eleanor, you may remember me. I'm Gopal Nemana, a retired cardiologist from Kaiser. You probably heard me through Sandy Barber, I guess. But good to see you, Mark. In the last 45 years, I'm still teaching. Bill Baumer is there. I'm still volunteering at UCD Medical Center as faculty, but in the last 45 years, I've seen a sea of change at Kaiser, and aspirin is one of them. Actually, I was taken off of my aspirins because I'm 81. My primary care physician said, no way, I don't want you to bleed because of my GERD. But I just want to congratulate you. I started with your 2 question marks at your presentation. And I say, a question is a line, the answer is a book. And you did it very well, Mark. Thank you.
Thanks, good to see you, Gopi.
Thank you. And Steve, are you on? You can, Stephen Chen is one of our pharmacist leaders.
He's not with us. I don't see him today.
Just made a comment in this chat box about what a PharmD is able to do at the top of their license. You guys can take a look at that. Any other questions? I see we're already at 6 o'clock. I don't know if we're going to be wrapping up soon, Hattie.
Of course, I always have a question. I am sort of famous for asking a lot of questions throughout my life. And one of my dearest questions that I ask many of our cardiologists is what a difference it makes to measure LDL 100 and have that concrete target as opposed to just on statin. I certainly believe that when we left the standard of LDL 100, that we saw a degradation in the progress on heart attack. So I'd just like your perspective on that and how soon it's coming back that we're going to have real targets, like for high-risk patients, LDL less than 70 or even less than 50.
Right. So, I may have a different take on that, but again, the energy spent on measuring LDL is, for most individuals, I wonder if the energy ought to be spent on making sure people are adherent to their statins. So using LDL to see that their number dropped a ton means the person's probably adherent. I mean, you can look at pharmacy records, but we have an adherence marker, which is did the LDL drop almost in half on a high intensity statin? And so, I think that there's room for both, but I think at least in many parts of the world and in this country, and maybe not in everyone's system, is that using LDL as a marker for adherence is awesome. And we can think about the next person whose LDL, it was 170 and now it's 165. It's like, you're not taking your blank, are you, sir? But when people tell me, well, the LDL fell from 165 to 101, what do I do? I just want to be frank with you. I get nervous about all the energy spent on that. And maybe we should focus that energy on the other person whose LDL has not fallen at all because they need effort on adherence. So I do think there's room for both. But I'm not certain that we want to reshift everything on LDL because I think a lot of energy is devoted on small reductions of LDL. So I think it's important. But using it as a marker for adherence, I think, is where it's most helpful.
Well, we could have a whole discussion about that for more than 2 hours, so we will not torture you all with that. But if any, Nirali, I know that you have young children that need you at this hour, and that many people have family obligations at this hour.
Not just young mothers, everyone needs to go eat. Yeah. But I think that I just want to say thank you again to our speakers, the lively conversation, and our community for engaging in the discussion. I think today really highlighted the importance of implementation, moving past the low-hanging fruit we know is there, and really thinking about engaging the community, engaging providers beyond physicians like MAs, pharmacists, et cetera, to get what we know out there. And, you know, I'll say the LDL is a marker of, are you taking your statin, but also, are you getting your vegetables, right? Like we heard about earlier. So we need to really engage across the scope. And I'm really excited to see what partnerships form after today's meeting. But yes, all people need to go eat and go home. So I think we should wrap up. Do you want to show a last slide?
Eat mostly vegetables, right? And use that as a spice, if at
Joe
all.
Sky and I will say plant-based diet all the way.
and I have to thank our folks from Sansum Diabetes who pointed out in that slide, which is a little different than some recent things out in the press, that if you get 10,000 steps instead of the 5,000 I've gotten so far today, it really lowers your mortality. So when I really grasped that slide earlier, I said to my husband, let's take a second walk today. Let's walk and see the sunset. Great. So that's what we're going to go do.
Okay, all right. Thank you, everybody.
Thank you so much.
Take care, everyone. Bye-bye.
Sorry, Steve Chen, that we did not promote you to our video panel. I didn't realize you were with us. So anyway, thank you so much for our wonderful presenters and leadership. And there are very few people on right now, but we'll just say that our next wonderful gathering will be on Monday, November 8th from 12 to 2:30 p.m. on heart failure and telemedicine. So good night, all. Thank you, Mark. You're wonderful. Let's work together more.
It was great. Such a wonderful group. Thank you so much. Bye-bye.
Thank you. Bye.